Hey, I'd love to talk with you all about the sort of critical processes that go into starting behavior change. And some of this you may have heard before, and you may be quite familiar with this. So for some of you, this may just be a refresher. But I hope to add some new information or introduce a new perspective on some of these issues. Um, okay. I have no financial conflicts I need to disclose. So let's start with asking a pretty basic question, which is, how do your patients get better? And I'm sure this is a pretty complicated question for many of you. We obviously think of delivering effective treatment. If you have a certain ailment that is required to be treated via a certain drug, you really need to provide that drug in order for the person to get better, at least in most circumstances. But of course, that's not always clearly the case. There are many other factors that sort of go into or contribute to positive outcomes. Many of these may be things like adhering to treatment. Medication is only effective, of course, if the person takes it, like you all know. With a behavioral intervention, it's particularly important that people adhere to the recommended treatment plan. Now, to do that, they have to have a fair amount of trust that their provider has their best interest in heart and that they are sort of in agreement that this is the best treatment for them or this is a good option for them. They ought to have positive expectations. We know that expectations play a huge role in patient outcomes. Many of you are, I'm sure, extremely familiar with the placebo and nocebo effects, that if people believe that a treatment is going to be positive for them, they tend to do a whole lot better. And so we need to do our best to foster at least positive, generally good and realistic expectations for what should occur. And overall, people need to be seen in a supportive healthcare environment. And if we can create that environment for them, people tend to do pretty well, and they tend to take our recommendations and follow through with them. So what I want to introduce here are the notion that there are several common factors that play a huge role in particularly behavioral interventions. And what I mean when I say common factors, you may be familiar with this term, but these are factors that occur in generally any therapeutic or healthcare relationship. These have been popularized in the psychotherapy literature because in psychotherapy, we spend a lot of time focusing on the relationship between the therapist and the patient. But this is also pretty true in generally any medical setting as well. So these are factors that'll play out in any relationship. We can boil them down to generally several categories. So there are factors that influence the relationship, such as the patient forming a therapeutic or working alliance with the clinician so that they have a feeling that you are on the same page and that you have their best interest in heart and that you're collaboratively working together to achieve the same desired goal. They also need to receive general warmth from their provider. They need to feel that you understand what's going on for them and that you're going to support them even if there are maybe embarrassing aspects at play or things that may be stigmatizing. For some patients, they need to feel that you generally see them in the most positive light and that you want them to do well. There are also learning factors that play a role. So with any patient interaction, you're going to give them, of course, information about their condition, about the treatment. They need to accept that that is realistic. We know that some people tend to have maybe some skewed ideas over what could be causing some issue or what could be the best way to deal with that. And they need to generally accept, at least to a good degree, that the rationale you've provided with why this treatment is the best, they need to generally align with that. And if they don't, they generally fail to follow through. And even sometimes when they do follow through, they don't get the same positive effects that we might expect. And of course, they need to effectively communicate with you about what's going well for them, what's not going so well for them. And if they don't feel comfortable doing that, then we tend to get pretty bad outcomes. Now, finally, there are action factors like they need to be persuaded to actually engage in the change processes, even if those may be very, very difficult, like starting up an exercise regime, trying to start to quit smoking or drink less alcohol, or start taking a daily medication that may be beneficial for them. They need to be persuaded to actually consider that. They, of course, need to adhere, and they need to believe that healing is taking place. Now, these factors, I just can't overemphasize how important these factors are. And the reason I do that is because meta-analytic evidence has generally told us that they're extremely, extremely important. I apologize that this figure came out a little bit blurry. I tried to boost the quality, and that didn't work. But so meta-analysis have told us, and this comes from psychotherapy, so it has to be taken with a grain of salt. Because these effects may not completely generalize to a primary care scenario or other medical scenarios. But what we see here is the y-axis represents the effect size of a given factor as playing a role in treatment outcome. And the width of the bars corresponds with the weight of the evidence, such as how many studies have shown this effect. And what we generally see is that common factors play a huge role in how well patients do in the long term. So these general factors that are mostly to do with the relationship you have with the patient and what they learn, what they agree is a positive healing process, those are going to be the factors that generally drive a positive outcome. I do think that these effects might be a little bit overstated for a medical practice, given that in psychotherapy, we do spend 45 minutes to an hour with a patient every single week. So the relationship is very, very, very important. But nonetheless, these factors ought to be expected to play a very similarly important role in a medical setting. What we see is generally the biggest important factors are these things like empathy and therapeutic alliance. So a patient feeling understood and that you and the patient are on the same page. Now, these specific factors, so things like the actual treatment that you're providing or the competence of the therapist, we don't see those play as big of a role in terms of effect size. But I don't want you to discount those for now, because I think it would be misleading if we were to say, well, the only thing that's important is your relationship. Well, no, we actually have to do something in treatment. And I'll give you some explanations for why I think we see these low effects. Now, some considerations for how we think about these common factors in time-limited settings. There used to be this assumption in medicine that there really wasn't that much room for creating a therapeutic alliance, even in a behavioral context. So when you're maybe encouraging a patient to lose weight, or you're encouraging, or you're doing some brief behavioral therapy to improve depression or anxiety, we used to think that the therapeutic alliance maybe wasn't all that important. And there were individuals who questioned, can you even really build an effective therapeutic alliance in a very brief setting? Now, this comes from a long tradition of psychotherapists who I think are really invested in very lengthy psychotherapy, that they believe that you really, really have to get to know a patient for months or years before you can even really have a good therapeutic alliance. And that tradition has really been challenged over the last 2 decades. What we found is you can establish a really good, strong, stable therapeutic alliance even in like 10 or 15 minutes with a patient. And that it still plays a very important role in outcome. And we also know that it can be done in a variety of settings by a variety of clinicians. People tend to do pretty well with it. The assumption that medical providers aren't establishing these relationships is just wrong. And the only evidence of differences amongst some clinicians is that sometimes there are some studies that say more experienced clinicians tend to be maybe a little bit better at this, which is somewhat reasonable, I suppose. However, I bet many young clinicians are very, very good at establishing good rapport and good common factors. There's also some evidence that some patients have strong preferences to receive care from a person of maybe a matching demographic or cultural background to them. And what the evidence generally suggests there is that if the patient prefers very strongly that, say, that they're seeing a female doctor versus a male doctor, then it's probably best if you do that. But some patients just generally tend to say, oh, I don't really care what gender my doctor is, and if that's the case, then they do just fine. So we just need to listen to patients when they say that they do have a preference and see if maybe that might be something we ought to accommodate. So otherwise, we know that therapeutic alliance can be achieved, like I said, quite quickly, and it tends to stay high. So that therapeutic alliance that you can establish with a patient in just like 15 minutes of your first appointment, the first time you've seen that person, it can get really high and sort of achieve like a ceiling to where it just stays good over time. And so that evidence suggests that if you do this well, you can establish the good positive rapport, and as long as you don't have major ruptures, they tend to trust you over time, and that tends to be correlated with a really good outcome in many other contexts. So how do we build good alliance? Many of you are probably very familiar with this. You're probably extremely good with your patients, and you do these things all the time. So I won't rehearse the obvious things like express empathy, but some other things I think are important. One topic that comes up a lot, and maybe this is quite highly discussed in your training programs or amongst you and your colleagues, is that authenticity is really important. And what that generally means is that patients like to feel as if they're being treated by another human being that has the same sort of struggles and difficulties and understands what they're going through. And so they want to see that you're not just sort of going in there and putting on a mask to say, hey, I'm this nice provider and this is what's indicated for you. They tend to see through that, and particularly some patients more than others can be quite suspicious of medical personnel and that they have the positive or best intentions for them. So if we convey that our care for them and our desire to see them reach a positive therapeutic end is genuine and authentic, and that we actually really do care about our patients, and we show that through our body language and our verbal communication, patients tend to view that as extremely positive, and they say, my doctor really does care about me. And that tends to be a very positive factor. We, of course, know things like active listening and devoting a good amount of time to conversing with the patient rather than just taking a couple notes, writing on the computer, or consulting with different sources. If we spend a lot of time with the patient, that tends to be generally good. So as much time as we can do on that, that's great. Patients also want to be held in high regard by their provider. They want you to see the best in them, and they like to be liked, which is completely unsurprising. And so what we can recommend in that regard is that we build off strengths and their goals that they set out. So if we say, hey, you're really good at this, like you really succeeded in this one aspect of your life, and that shows how strong and determined you can be when you really care. So I see no reason why you can't succeed in this other domain. People like to be complimented, they like to be liked, and if we can emphasize their strengths, we generally build their capacity and their positive expectation for a good therapeutic outcome. Now, finally, we should always, of course, assess their attitude towards treatment or a specific treatment approach and how well they understand treatment. You probably already do this every day, but I think it can't be overemphasized that we should always check in with people to say, hey, so are we on the same page that you think that this is the right approach for you? Do you have any questions about this? And if so, I'm happy to discuss them. And finally, I really think it's important to check in regarding the quality of your relationship. This was something I was introduced to quite a while ago during my clinical psychology training. And what I learned, what was offered to me as a tip was, especially the first time you meet with a patient and you wrap up, you ought to check in with them and say, hey, is this going okay? Do you feel like we're good here? Or am I not understanding you? Do you feel comfortable talking with me about issues? And patients will, a good amount of time, tell you if there's a problem or say, yeah, I feel okay, or yeah, you seem nice. Those may be flags that I'm not sure we're on the same page, so maybe I need to work a lot harder, or maybe this patient would benefit from seeing a different provider. And I think also the benefit of doing this sort of check-in to say, how are we doing? Do you feel comfortable working with me on this issue? They see that as a positive because they see that as you are trying to make sure that things are good and that you're willing to address problems if there are some. So I think that can be a really helpful tip, to just continuously check in. It's not harmful. It shows that you care and that you want to make sure that this is the right setting for them. Excuse me. So let's move on, though, to specific factors. So let's assume, which I think is a reasonable assumption, that most of the providers tuned into this call do pretty well in terms of establishing good therapeutic alliance, good common factors with the patients. So what does that mean for what we do specifically? So that maybe the specific approach we take towards a behavioral problem. So is that going to be a cognitive behavior therapy informed approach? Is that going to be an approach that maybe emphasizes a different school of thought? There are sort of a litany of resources that you can go to in the behavioral world that might say you should really take a different approach, a totally different theoretical orientation. And many of you are probably very, very familiar with cognitive behavior therapy because that tends to be the predominant school of thought that is taught these days, generally because it boasts a good amount of evidentiary support. But there are many other approaches out there that some would consider to be very fruitful approaches, or very beneficial for some patients. So if we consider that, and then we think about how important are specific factors, if we believe that common factors are really the only thing that's important, if the patient trusts you and they believe that you have their best interests and they expect that whatever you tell them is going to be the best way to heal, they're going to do well. If you believe that's the only thing that's important, then I suppose it doesn't really matter what the specific recommendation is, or how you're accomplishing a behavioral or cognitive or emotional change in that individual. And that idea is sort of jokingly referred to in my field as the dodo bird hypothesis, which is this idea that, hey, everyone wins, everyone gets prizes. It doesn't matter if you're a CBT guy or a psychodynamic guy, whatever. Everything you're doing is good. If you're a good therapist, you're doing a good job. Now, that idea I'm a little bit suspicious of, because I do think that what we do in the room matters quite a bit. And this is pretty well supported by some evidence. And this is a paper that was actually one of the first that I published in my career. And what we did was we looked at therapeutic alliance amongst behavioral health care clinicians. So these are psychologists, social workers, counselors who are embedded in family medicine programs or community health centers. And they're primarily dealing with, behavioral health, but also medical issues that have a strong behavioral component. And what we looked at was how quickly can they establish a good therapeutic alliance, and does it make a difference in their long-term outcome if they see that provider over multiple sessions? And what we found was, like I said before, they can establish really, really high good therapeutic alliance in the first session, and it doesn't really change after that. It's kind of like, if you do it well the first time, there's really no room to grow. I mean, you're doing everything you need to do. But it did not have any relationship with long-term outcome in this context. And so our conclusions were that often you can reach a ceiling effect very quickly to where the patient trusts you and everything's going great, but that's not going to really play a role in how well the patient does months down the line. What actually matters is that you harness that good therapeutic alliance and you put it towards positive specific factors. So I think these things are extremely important. If you have poor therapeutic alliance, you're probably not going to do very well. But once you have it, then you need to do something with it. So it's necessary, but not necessarily sufficient for positive outcomes. Now, these critical specific factors that I think cut across any sort of behavioral intervention that you do are going to be keeping an agenda in general, that we have goals, that we have an outline for what we think a patient should be doing over the sessions and where we should be going. And if we're not hitting those goals, we need to alter our approach. And we need to have a specific agenda for the setting for each appointment, so that we're actually getting to every single thing we need to with the patient. So if the patient has multiple problems, we need to not focus on just problem one and sort of get carried away in that. We need to make sure we hit everything. We need to assign homework, because behavior change occurs outside the session. It doesn't occur in the session, particularly if it's a short session, like 10 to 20 minutes. So all the work has to be done outside of session, and we need to be sure that patients, that we actually know what's going on outside of session. So I think that just getting these general reports of, hey, did you do what I told you to do? I don't think that's quite good enough. I think we need to find good ways in which patients can give a detailed account of what they did. So that might be a log of how many times they went to the gym, or a log of how many cigarettes they smoked a day, or how many times they went to a positive thing in their life, like they actually engaged in things that they said they were going to do, or they did their exercises, whether they be mental, behavioral exercises, whatever they are. We need to have a way for tracking that and going over it in session. And we need to ask that, of course, at the end, there's a specific change. So what are we going for? Are we going for a 50% reduction in symptoms? And if we're not meeting that, then do we need to do something different? So we need to set SMART goals. And we'll go over those in much more detail, because I think that those specific factors all sort of depend on the problem that you're taking on, and of course the approach. But what I generally wanted to get across today is that, at least in our school of thought, and this certainly plays out, I think, in many family medicine settings and many medical settings in general, that those common factors really can't be overemphasized in terms of their importance, but they're not everything. So I suppose they can be overemphasized a little bit, that they are very, very important, and that we should always be paying a ton of attention to it. These are the factors that tend to drive patients who say, I really like my doctor, I trust my doctor, I want to go back to them, they really know what's best for me, and they follow through. But you actually need to harness that information and leverage it in order to accomplish the specific goals that you want to. And this applies to generally any sort of problem. And so in future sessions, I really want to get to things like how do we accomplish, how do we use a positive therapeutic alliance to maybe move someone towards a pre-contemplative stage to where they're considering making a behavior change to actually acting on that behavior change? Or how do we leverage that to completing their homework assignments or doing something that may be really challenging or stigmatizing to them? How do we use these resources to accomplish our goals? So with that, I'd love to just turn it to discussion. And what I'd love to hear from anyone in the audience is any questions, concerns, or discussion points, particularly if anyone could think of a case where they felt like maybe they weren't on the same page with a patient, and those common factors really weren't lining up as well as they hoped, and maybe how did they improve it, or maybe you're searching for a question of why wasn't I able to get there with this patient? If we have anything related to that. People can feel free to type into the chat as well.